Awesome. I hope everybody is doing wonderful this morning. I know it's 8:30 in the morning for you all, but here in the United States, I'm in Atlanta, Georgia, and it's 9:30, and I have plenty of energy to get you guys awake and going today. But we're going to be discussing for just a few short minutes the GI effect stool profile. If you think about the majority of your patients that come to your clinics, the majority of them have some type of a GI concern. The last article or study that I saw, it's about 60 to 70% of patients have some type of a GI concern. And so having the powerful tool of a stool profile can help you get down to the root cause of not only their GI concerns, but even some of their other clinical concerns. So here we have the objectives for the presentation. We're going to go over the actual GI effects report. We're going to go over the various features and also talk about the GI testing value. So what sets Genova's stool profile apart from other companies? So one of the biggest questions I always get asked is, how do I know that this patient that's sitting in front of me is a good candidate to order the GI effects stool profile? And so I just wanted to address that from the beginning of our conversation. So if they have diarrhea, gas, bloating, pre-existing GI conditions like inflammatory bowel disease, cramping, dyspepsia, or heartburn, or irritation within the GI tract, these are your classic GI symptoms in which you would consider ordering a GI effects stool profile. But as many of you know, the GI microbiome, the GI tract, it not only deals with the gas, the constipation, the bloating, but it can also influence things like your mood because the majority of your neurotransmitters are produced within the gut. It can influence things like the health of your skin because there is a skin-gut connection. It can influence, for example, with diabetes, because the pancreas is trying to secrete that insulin from the beta cell, the endocrine function of the pancreas, that can also influence the exocrine function of the pancreas and inhibit or negatively impair your body's ability to digest and absorb your macronutrients, which will put you in a state of nutrient depletion. So ideally, these conditions also to the right-hand side that might have some aspect of rooted in gut health, we also want to consider ordering the GI effects stool profile for further evaluation. So now let's go ahead and dig into the various aspects of the GI effects stool profile. And I use the word dig into on purpose because if you notice, our profiles are divided into kind of this dig framework. The D stands for digestion, the I stands for inflammation, and the G is the gut microbiome. So if you look at the front page of the report, we provide this functional imbalance score, and it gives you a score out of 10. The higher the number, the greater the need for support for that individual category. And so it helps you to understand, well, what areas of GI function do I need to focus on first for my patient? We also provide the therapeutic support options, which kind of gives you direction in regards to, okay, if they have, for this example, low pancreatic enzyme production, what therapies might I consider? And you might highlight the digestive enzymes. So you only highlight or think about the one that's applicable for the results that we found on the profile. So I'm just going to go back really quickly. If you look at, again, that DIG framework, the largest part of the framework was really the gut microbiome. And the gut microbiome is really looking at these commensal bacteria. And until recently, we've really struggled as a medical community to really understand, well, what do I do with all of this DNA PCR commensal bacteria results? You know, you have different methodologies in literature, you have discrepant results in publications. What does it mean when one bug is high, when one bug is low? And there's no real research about the bacterial patterns. And what I really appreciate about Genova is that because we have amassed a database of hundreds of thousands of complete stool profiles along with a lot of questionnaires, we were able to use technology to help answer some of these questions so that the results that we give you are actually actionable, so you know what to do looking at these commensal bacteria. And so here you'll see page 2 and 3 of the report, and you'll see that it's divided into the abundance, the dysbiosis, and the balance parts. And that again is really driven based on the database of the complete profiles that we have along with questionnaires. So looking at those individual sections a little closer, with the total abundance, it's the sum total of the reported bacteria compared to the healthy cohort. So when we compare you to the healthy cohort, if you have higher amounts, that means that you have a microbiome overgrowth. That could be something as simple as I'm taking a probiotic or I eat sauerkraut every day. It might not be a problem. However, if the patient has small intestinal bacteria overgrowth or SIBO, as to which anaerobic bacteria are now populating the small bowel, then it might be a problem to have this microbiome overgrowth where they might present with postprandial gas, bloating, abdominal pain, nausea, vomiting, those types of symptoms, and they get worse after they eat. Then we have a potential microbiome deficiency. We oftentimes see this with eating disorders, current or past. We often see it with antibiotic, antimicrobial usage. We can also see it with individuals who have kind of a poor quality diet or colonic colonoscopies as well. So when we have that deficiency picture, we want to see, well, why is it deficient in the first place? And of course, replacing good microbiome with like a probiotic, for example. The dysbiosis pattern. So the inflammation-associated dysbiosis was established with a prestigious research institution here in the U.S., in North Carolina, along with ourselves, where we were able to create this inflammation-associated dysbiosis score. And if you want the publication in PubMed, you can always refer to that as well. But what we're looking at is the shift of the microbiome, the shift of the byproducts of the microbiome, like your short chain fatty acids, that occurs with individuals who have ulcerative colitis or Crohn's. And so the closer you are to that shifting of the microbiome, the higher this value. And that would mean that, hey, we need to address dysbiosis. And then with the methane dysbiosis score, this one was developed in-house looking at methane dominant small intestinal bacteria overgrowth or SIBO tests and the microbiome on this profile, as well as their byproducts. So the higher the number, the greater the likelihood that you're making more methane archaea or bacteria. And so we can evaluate, is it more of just an imbalance of the good bacteria, or do we in fact have to look at small intestinal bacteria overgrowth? Based on the dysbiosis patterns, you're put into zone 1, 2, 3, or 4. In zone number 1, you can see it has low methane, low inflammation. Zone number 2 would be higher methane, but lower inflammation. Zone number 3 would be high inflammation, high methane, and zone number 4 would be high inflammation, low methane. We do provide that insight on the right-hand side of our report, a little bit of commentary, so you don't have to remember what these different zones mean. And we also say, like, for example, in zone number 2, we typically see maldigestion of fecal fats and bad bugs and SIBO. So we do give you the classic pattern we traditionally see within each of the zones so that it can give you something to look at the test, see if your patient has these different conditions or issues going on. The balance is the intersection of two different measurements, the reference variance score. So that tells you out of 24, how many anaerobic bacteria are out of range. And then the healthy pattern continuum, the higher the number, the more you fall in alignment with our healthy individuals. So we want this result or the U bubble to be in the green zone. And, we always think about, your diet and using prebiotics and probiotics to influence the commensal balance. But one of the things that really surprises me each time is actually exercise is something that greatly impacts your microbiome. Those who have a regular exercise regimen or who are athletes, we can say, they tend to have a higher commensal balance than those who are more sedentary, which always fascinates me because everything in the body is all interconnected and it's totally cool to me. But here we have the relative commensal abundance at the bottom. This is the same as the commensal abundance that we talked about on the top of page 2. We're just going into more detail regarding the individual bacteria phyla measured on this test. So although we look at 24 bacteria, they're grouped into phyla or similarities, and we have 7 of those groupings. So you can see them listed here. The middle dark line is where we found the healthy cohort to be, and the colorful line is where your patient lies. And on the right-hand side, we provide some information. For example, the Bacteroidetes phylum, if it's high, we do see it high in individuals who have more of an animal-based diet. So we do provide insight into when we see it high, when we see it low, based in literature, what different dietary foods or things might influence it. That way you can start to think about ways to guide your patient regarding dietary changes to support healthy microbiome balance. So what else? So the next few pages of the report here, we're really going into more detail regarding digestion, absorption, inflammation, immunology, gut microbiome, the DIG framework. So let's look at the next page of the report. So here we have the D, digestion and absorption, I, inflammation and immunology, G, gut microbiome metabolites. Again, that's that DIG framework that I was mentioning earlier on. And you can see regarding the front page of the report, each of these sections are scored using that functional imbalance score. The higher the number, or if it's red, that means that we have a lot of work to do in that individual category. So let's look at each of these different groups in more detail. So for the D, we have digestion and absorption. So here we're looking at your body's ability to break down your macronutrients, or your body's ability to produce the pancreatic enzymes from the exocrine function to address fats, proteins, and carbohydrates. The next one, products of protein breakdown. How well are you breaking your protein down? Well, if we have a lot of product of protein breakdown in the stool, then that would indicate that you're not doing a good job. And maybe it's because you don't have enough stomach acid, for example. Total fecal fats. When this is high, that means we have more fat in the stool. Maybe you're just doing a ketogenic diet. But we can also see higher fats in the stool if you don't have adequate bile to break down your fats to use, or even conditions like celiac disease, where you have a blunting of the microvilli causing you to malabsorb things, especially your fats. And again, on the front page of the report, it's going to fall under this maldigestion pillar, where you'll see, for this example, the pancreatic elastase is a little bit low, and clinically we would recommend digestive enzymes until we can figure out what the root cause is, whether it's pancreatic because of cystic fibrosis or gallstones or something like that, or whether it's a non-pancreatic cause such as small intestinal bacteria, overgrowth, inflammatory bowel disease, celiac, or smoking or something like that. The next section, the I, we have calprotectin, which is a neutrophil inflammatory marker. And this one, when high or at least above 50, we say retest in 4 to 6 weeks, because the reasons you can have neutrophil inflammation are things like malignancies, inflammatory bowel diseases, and even infections. So when this is high, we really want to retest in 4 to 6 weeks to make sure the inflammation is actually coming down. But when this level gets super high and we have some really concerning symptoms, we might have to suggest a GI consult for some imaging. And because it could be due to like Crohn's, it's not just looking at a colonoscopy. We also want to consider an endoscopy where we're evaluating from the upper part of the GI tract to see if anything's going on. Eosinophil protein X is eosinophil-mediated inflammation. So things like food allergies, environmental allergies, malignancies, parasites, inflammatory bowel disease, that can also cause the eosinophil protein X to elevate. So when it's high, we need to investigate those things further. Secretory IgA, that's basically like an alarm system that says that your immune system is responding to something, whether it's responding to a bacteria, a yeast, a virus, or whether you have intestinal permeability or leaky gut. But also it could be negative food reactions like food sensitivities or delayed type 2 hypersensitivity IgG reactions, in which an elimination diet or food sensitivity testing might be indicated. And again, for the front page of the report, under the inflammation pillar, you can see these various markers here. Now, later in the report, we are going to talk about the fecal occult blood, but it does fall under this category because if you have blood in the stools, it can indicate inflammation. For the G, or the gut microbiome metabolite portion of the profile, we're looking at these byproducts of our gut microbiome, so short chain fatty acids, as well as beta-glucuronidase. Well, it brings about an important consideration knowing that these are byproducts of the microbiome. If you have low amounts of good bacteria, then it's going to cause these values to also potentially be low as well. But when it comes to your diet, the bacteria for the short chain fatty acids ferment those insoluble fibers in the diet, the prebiotics in your diet. And for butyrate, we talk about resistant starches like your seeds and legumes. So there is a dietary component as well as a microbiome component for us to make our short chain fatty acids, which are super duper important when it really comes to maintaining your tight junctions, when it comes to breaking down your foods, when it comes to energy for the melanocytes and for just the health of your GI tract. We really need those short chain fatty acids. Whereas beta-glucuronidase, it's actually an enzyme that can cause you to recirculate bad stuff like toxins, hormones, drugs, carcinogens. It interferes with phase 2 detoxification. So when the beta-glucuronidase is elevated, then we need to start thinking about things to help decrease it, like probiotic or milk thistle or fiber, or things to help block it, like calcium D-glucarate found in apples, citrus fruits like your oranges, and cruciferous vegetables. Because again, if you're in this state of continuously recirculating hormones or carcinogens, your risk for imbalances of hormones or cancer is higher. Your risk for not processing medications very well or getting a lot of side effects is higher because, again, you're just not clearing it very effectively. And it's going to be under the metabolic imbalance pillar here. So some GI testing values that I really want to highlight really quickly is, I'm not sure if you guys are aware, but in terms of getting calprotectin FDA cleared, that was really a Genova. Genova had a huge hand in that because we were one of the first labs to actually offer calprotectin, and we had a large part in getting it FDA cleared along with some of our other inflammatory markers. And then we measure these byproducts of the microbiome. So we're really looking at this interaction between the microbiome and the individual as a host. So that's definitely one of the many important GI testing values that our profile offers. The next page, we're looking at the commensal bacteria, or the individual bacteria that helped us to understand the dysbiosis, the imbalance, the abundance markers that we saw on the front page of the report. Here, they're each listed out. Now, remember, I mentioned on the earlier slides that with commensal bacteria, it's kind of difficult sometimes because we don't really know a lot about these individual bacteria and what exactly to do. But fortunately, because literature is ever evolving, we are now starting to gain a better appreciation for various bugs. And based on what we know as a lab and in literature, we do have this commensal bacteria chart for you. And so you'll find the results of these abundance and variance under the dysbiosis pillar on the front page of the report. But let me just highlight one bacteria that has been receiving a lot of popularity, I guess we can say, more recently, which is Akkermansia. This bacteria has been associated, when it's low, with obesity, diabetes, inflammation, insulin resistance, inflammation within the liver, gut permeability, or leaky gut. It actually produces acetate and propionate, which are your short chain fatty acids. And it can improve your intestinal barrier integrity, but it also can limit toxicity of sulfate reducing bacteria. And your sulfate bacteria, they tend to have more of a pro-inflammatory impact in the GI tract, so it can help keep that at bay. And that's why there are a lot of companies now looking at producing probiotics that include Akkermansia because of so many of the beneficial impacts. But until we get to the point where we have probiotics that, can incorporate Akkermansia within them, we know that things like pomegranate extract, cranberry extract, like your polyphenols and prebiotics, can help to support the growth of this this bug. And just to go back really quickly on the previous page, the Akkermansia is found under the Microbiota phylum, the very last one. So again, usually when it's low, we think about this metabolic syndrome picture. We think about inflammation, but we also need to think about intestinal permeability as well. And there it is, highlighted there for you in the circle, and some therapeutic considerations there and why we see it high versus why we see it low. The goal is to have an increased level of this bacteria. So on the next page of the report, if we're looking at culture, so everything that we talked about until now is DNA PCR, and now we're transitioning into culture, looking at how well things are growing on a Petri dish. We're looking at lactobacillus, Escherichia coli, bifido, but also additional bacteria and yeast. Anything that grows out, we identify. And we also look based in literature to see if it can maybe be a potential pathogen or if it is a pathogen. So if it's a potential pathogen, we need to look at the clinical presentation of the patient, because most people who have, let's say, a Klebsiella are asymptomatic, but some people might have GI cramping, abdominal discomfort, or looser stools. And if that's the case, we want to consider treatment. And the good news is that anything that flags as a potential pathogen or a pathogen, we do sensitivity for botanicals and prescriptive agents. For the yeast, again, is your patient symptomatic? If so, then we have some sensitivity information to look at treatment. So again, on the front page of the report, it's going to fall under the infection pillar there, and you can look at various treatments based on what is identified. So this is what our sensitivity page looks like for the yeast. You can see if it falls under the S category, that means it is susceptible. So you want to go ahead and use these agents for treatment. For natural agents, you want it to be as close to the high inhibition as possible. But I mean, these that are halfway are actually doing a pretty good job at limiting the growth of the Candida species. Same thing for the prescriptive agent. For the Klebsiella, we can see you would use those that fall under the S category, and you want to use those herbs that have higher inhibition. But again, using a combination of these herbs would also be an okay strategy. So what you notice so far, hopefully, is that we're using PCR, we're using culture, and I'm going to show you in just a bit. We also use microscopic methods so that we can identify any relevant organisms, and we can really help guide you in terms of treating your patient, figuring out what the root cause is. We also recover live organisms, the yeast and the bacteria, and that's what allows us to do the susceptibility treatment, so we can identify what botanical agent or prescriptive agent is more, does that bacteria or yeast respond more to. Now, the next page of the report, we're looking at parasitology. So here we're doing ONP, ova and parasite, the gold standard of parasite evaluation. If you have a patient that you suspect has a parasite, whether it's because international travels or symptoms that might correspond with the parasite, you might want to consider ordering a 3-day stool sample, same price as your 1-day stool sample. The only difference is that they will collect for 3 separate days this one page. And then on the 3rd day, they'll do like the mass collection of all the other tubes. But that way we're able to identify on separate days, do we have any parasites in those stool samples, which helps to increase our ability to recover anything if present. So if it's not detected, we say not detected. If we find it, we quantify it as rare, few, moderate, and many. We also do PCR of these 6 parasitic targets, and we will say if it's detected or not detected. Now, one of the biggest misconceptions is that people feel that PCR technology is perfect, and that is totally false. 15% of known samples will have a negative PCR result. So that means that PCR is not perfect. This is why at Genova we implement many different technologies so that the strength of one technology can kind of counterbalance the weakness of another technology. That's why we don't just rely on one technology. Additional results, fecal occult blood, we use FIT testing, meaning that upon one positive result, you need to investigate further. There's no medication, there's no supplement or food that can impact this marker here. So you need to evaluate if it's a female, whether on their menstrual cycles, which you should not be collecting on your menstrual cycles, but sometimes it happens. Are there any fissures, hemorrhoids, or do we need to refer to a GI doc to figure out where this bleeding might be coming from or the blood might be coming from? Color consistency are reported by the patient. And there you have it. Another beautiful testing value here is really going to be that we are really trying to get down to the root cause of the majority of gut complaints, but we also do use this test to figure out, well, could skin issues be rooted in GI dysfunction? Could your mood be rooted in GI dysfunction? Could the flares of your autoimmune condition be rooted in GI dysfunction? So that's why I feel that stool testing is something really great to add to your clinical practice. And if you have not already done a collection of the stool test, I would strongly suggest it. I think you'll be very pleased with the quality of the results that we produce from Genova and how everything is very, very actionable. Any questions?
Thank you, Dr. Leonard. Yes, yeah. We have one question for you. There is one question asking about what is the difference in profiles between ages and sex. If you have seen similar profiles for similar kind of age and sex.
Great question. So our healthy cohort did encompass both females and males. And when we did a deeper dive into literature, we did identify that for the biomarkers that we have here, there are really not many differences between those who are female and those who are male. Now, when it comes to age, if the child, like for a child, they usually have a really robust ability to produce pancreatic enzymes. And so their digestive abilities are usually really great. And so let's say we have a child who has a pancreatic elastase production of 200, that would definitely send up alarms like, okay, something is really wrong. Whereas in an adult, we might say, maybe something, let's just start off with some pancreatic enzymes, right? We would take it a little bit more seriously. In kids who are less than 4 years old, the inflammatory markers like calprotectin, eosinophil protein X, and fecal secretory IgA, according to literature and what we've seen here in the lab, they do tend to skew a little bit on the higher side. And so it might not warrant panic per se when those markers are a little bit on the higher side. We definitely do want to look at clinical presentation. But those are the biggest differences that we see in terms of age. And with gender, again, we're not really seeing many differences regarding like short chain fatty acid production or digestive things. We're seeing a lot of consistencies.
Thank you. How do you measure the metabolites of the microbiome? What is the methodology that you use?
Great question. So our methodologies are listed on the report. Let me see here. There we go. So you can see here, methodology is listed right here. Do you see where I'm kind of circling right there? So in every single report, we list our methodologies for every section if it does change.
How do you determine a false positive? When do you know that you had a false positive? How do you know that?
Great question. Great question. So and you're saying specifically for PCR, okay.
Yes, for PCR.
When it comes to PCR, one of the biggest things that we really consider is a clinical presentation of the patient, right? And that's why, again, I appreciate that we're not just relying on PCR because, again, 15% of known samples are not going to show, I guess we can say they'll be false negative, right? But that's why, especially with the parasites, we also look at O&P or ova and parasite evaluation. So that way, that technology can start to minimize the deficits of using PCR.
Well, thank you very much, Dr. Leonard. We are going to have all the questions from the participants, and we're going to send it to you by email so you can answer them, and we're going to get back to them. Okay? Thank you very much.
Enjoy. Bye, everybody. Have a wonderful conference.